started in just a few seconds now. I just want to make sure everybody can hear us okay with our microphone and that it's coming in clear. If not, if you want to type in the chat box if you're having problems, and then my lovely colleague Christine will be able to help you out. As well, you will see we're just wondering where everyone is from. So if you could just fill that out, click the box where you're from and hit send, and it will come to us. So we'll give you a few seconds to let me know if you want to type in the chat box whether you can hear us loud and clear, and if you could fill out the poll. Perfect. It's looking like people can hear us good. We just wanted to make sure we weren't too choppy. So if everyone could take a few seconds and fill out our quick little survey so we know where everyone is from, that would help us out, especially for our speaker, Catherine, so that she has a better idea of where people are from. Give you a few seconds to do that, and then we'll get started. Okay, I will ask Christine if she can pull up our first set of slides so we can begin our presentation this evening. If you have any problems at all during this presentation, please type in the chat box. Christine will be able to help you out with any of the problems that you're having with that. So with no further ado, we'd like to start. So our 4-session series is called Dying with Dignity, End of Life, Seeds of Hope. And tonight we will have a guest speaker. Before I go through that though, I just want to remind everyone that we do have other learning series within our family learning series. We have an early stage, the middle stage, living with change, the transition to alternative care, which is more kind of late stage, and then the one program, which is this evening, the Dying with Dignity. Learning outcomes, fairly straightforward. We hope to understand the philosophy of person-centered care. We'd like to be able to define what a good death is, to understand what decisions a care partner may have to make at end of life, and to understand the benefits of advanced planning. As far as our series goes, so tonight, this evening, we have ethical choices, and we have a clinical ethicist with us here. Next week, we will have hold on, just losing it here. Next week, we have end of life care, and we will have a palliative nurse coming in. Our third week, which will be November 29th, we will have a bereavement specialist talking about saying goodbye. And December 6th, our last one, is a lawyer is going to come in and talk about the paperwork that has to be completed upon someone passing away, and which paperwork should be done quickly and which ones you have some time. So that's kind of going to give you an overview. If you cannot make one of the sessions, they are recorded, and you will be able to come back onto Asant Cafe and go into the recorded sessions and find the one. Or if you want to go back and re-listen to one, it will also be there for you. I want to start with a little quote from Christine Bryden from her book, Who Will I Be When I Die? Christine was diagnosed at about the age 46. And she has written a couple of books since that time. And as you see, her quote is, "We do not want to be smothered by your care, nor isolated by your denial, nor cast aside as a victim of your grief. But we want you to be a care partner, walking alongside us to meet our increasing needs." In the past, we've had people ask how they can download the presentation as well as any extra resources, and we will be able to, you'll be able to download these, we hope by Thursday. If you come back into the Assant Cafe, there will be instructions for how to download the slides that we show you. Before I turn it over to Catherine, I do want to talk just quickly about being person-centered. So we use this formula, and it's D equals P plus B plus H plus NI plus SP. If you're like me, the first time I saw this, I panicked because I thought it was some math equation that I was going to fail at miserably. I was very happy to find out this is an equation Dr. Thomas Kitwood came up with to really help people understand person-centered care. So the D portion is the person living with dementia. So the D is the person living with dementia. And as Thomas Kitwood said, the person living with dementia, and sorry, the slide looks a little bit, it looks like it's moved on us somehow, but P is personality. And so as Kitwood was trying to say, every person living with dementia has a personality. They have their own biography. So we've all grown up. We all have our own different history, our own biography. They come to us with different health issues. So some of your family members may have hearing issues, heart issues, and some people, family members, may be just absolutely physically fit and their health really okay. So we have to look at kind of the whole person. The NI is the neurological impairment. So again, is your family member in the later stages, nearing the end of life, or are we more in that earlier part? And even within the stages, everybody can look different. And then as well as the social psychology or the social physical world around us. So whenever we're thinking about a person who has dementia, we need to remember that they're made up of all of these parts. There's just not one thing to them. They don't just come to us. They're just not a disease that has neurological impairment. They just don't have their social physical world, meaning they live in a care center or they're at home. It's the whole piece of the person that we need to think about. And so we like to show this to everybody in our programs because it gives you a really good idea of what Kitwood was trying to tell us by considering the whole person and not just a part. And again, this work here is from Kitwood. So in order to meet the physical, social, emotional, and spiritual needs of someone with dementia, we must understand their unique life experiences, support systems, personality, and kind of the so on piece. So we do have a suggestion for a reading. It's called Going From My Sight, and that's the Eileen Shami had written it, and it's more than body, brain, and breath. And so it's quite a nice reading. We are not going to read it out here today, but it does really tie in with our program this evening. So with that, I am going to turn us over to Catherine Duffy, and Catherine is going to walk us through our session this evening. If you have questions for Catherine while she is speaking, please again feel free to type them in the chat box, and then I'll be watching them as well just to help Catherine to make sure that she can get through everything and still be able to answer questions. We will for sure take questions at the end of the session as well. So everybody who's joined us again, welcome, and I'd like to introduce you to Catherine Duffy, and she's a clinical ethicist with Alberta Health Services.
Thank you very much. I'm just going to scooch up so you can hear me. I really appreciate that. I agree, slightly frightening equation when I just saw all those letters, but the message behind that is just so important when it comes to sufferers of dementia and all people really. And I think it's very easy for us to forget that whole person picture in healthcare. So I really appreciate that, kind of setting the stage for my my talk here. So I think it's sometimes helpful to start with a bit of clarification about what ethics is. And this is a word that's probably familiar to many of you, although we probably also have our own variations on what we think it means and the definitions. And so the way that I think about ethics is I kind of have three statements here that I think capture it. So one way to think about it is that it's the thoughtful, careful, and systematic examination of our values, beliefs, and beliefs that underpin our attitudes, decisions, and actions. So when I use the word values, I'm really talking about what's important to us, right? What's fundamentally important to us as humans, what's important to our loved ones, our care partners, our family, our physicians, all of that. So that's the values piece. I think it also asks the question, what do we owe to each other and how can we live up to that? Not just within the context of healthcare necessarily, but just as human beings on this planet. And also when my role as a clinical ethicist, and I'll tell you a little bit more about that in a bit, often ethics is about figuring out what can be ethically justifiable, or a little bit like what's right and wrong, although I don't love thinking about the world in that way because often it's not that black and white. So you might be wondering what a clinical ethicist is. This is a fairly specific role, and there are clinical ethics services across and in almost every health authority or system across Canada and in around the world. Really, it's a small but ubiquitous group profession, really, and it's a person who is usually within a healthcare system who assists patients, families, loved ones, and the healthcare team to resolve issues where there may be disagreement or uncertainty about how to proceed. And in my experience with sufferers of dementia, I'm often called in when there's uncertainty about care plans, about what the best way forward is for that particular patient or resident. And so that's my exposure to some of the challenges that come up in this world. And so that what I'll be drawing from in this talk is that experience when I talk about the types of decisions that come up and the ways to think through those when those do appear. Maybe you've already encountered some of these already. And a really important part of my role is especially to help healthcare providers think through this as well, just because there can be some challenges in understanding the trajectory and how this particular illness tends to work. When I'm thinking about specifically the ethics of care partners, and that's who I'm imagining you are, I ask the kinds of questions that come to my mind are things like, what does it mean to be a good care partner? What is the best decision for the person I'm caring for? How can I fulfill my commitments to that person? And how should decisions be made? And these are not easy questions, and I think over time the answers will change, but they're important things to keep in mind. And it's not easy. It's, as I say here, it's exhausting work, especially without the support of others. So I think one of my main messages would be that we're in this together, and that the best ethics is done in conversation and partnership with others. So as much as we can achieve that, that would be good. So some of the ethical issues in dementia care depend on where folks are in their trajectory. So there may be in the early stages more sort of patient-driven decision making. Ultimately, the sorts of things that tend to come up are balancing the interests of safety with allowing people to maintain their independence. I use the word here autonomy, which is a bit of it's a needlessly fancy word. Essentially what it refers to is the right of people to make decisions for themselves as much as they're able to. And one of the key things that we tend to think is really important, certainly in our westernized societies, all over the world, really, in varying degrees, is that people have a say in determining their own life course and what happens to their bodies. And so we try to pay close attention so that we're enabling people to maintain that ability as much as they can as their disease progresses over time. Often there are decisions to be made about food and nutrition and how that can be provided and when. And there's also the challenge of determining appropriate goals of care over time. So you may have already had exchanges in healthcare where people are asking you what your goals of care designation is, and there's these letters and numbers that you're kind of asked to choose, really. And there's a bit of murkiness around that. And when I'm talking about goals of care, I'm not so much talking about what's that number or letter. What I'm asking is, what are we trying to achieve at this phase? What are we hoping to get in the next few weeks to months to years? And what interventions, what care, what types of supports are going to enable us to get there? And then part of those decisions is really the decision about whether to pursue active medical treatments. So Arlene already talked about how some people with dementia don't only have dementia, there are other things that are going on, and there may be questions about what would be an appropriate type of medical treatment for that within the context of that dementia. So when I used the word earlier, values, I said values are kind of these fundamental things that are about what's important to us. And there's some things that tend to be really important to almost all of us from varying degrees from time to time. And certainly these values are also really important when it comes to interacting with the healthcare system. You might have noticed that your healthcare providers come with their own set of values too, and you know, whoever that is, whether that's a nurse in acute care or a care aide in a residential care or home care, whoever that may be, we're constantly bumping up against people who also have their own set of things that they think are really important, both professionally and personally. The sorts of things that tend to be important are that we work to create benefit and promote well-being, especially for our patients, residents, and for those our loved ones in this context. Often we're really trying to minimize harms, and often that means we're careful about safety, right? Are we enabling a living situation where people can be reasonably free but aren't going to put themselves in harm's way in a way that can be avoided? And that might be, you know, harms of physical harms, could be emotional harms, psychological harms. So we think about that pretty broadly. We often want to strive to maximize freedom and independence so that we're not we're not assuming that because somebody has some impairment that they're unable to have any type of freedom and independence. Certainly there's a balance to be struck there, and it can take some work to figure out what that is. Often it's really important that we preserve as much function as we can, and there can be various ways to do that, or to preserve function in a supportive way. So enabling people to continue to go out and do things that they like, but perhaps finding ways to provide support so that with a partner to go out and do that work, or a day program or something, so we can preserve function through relationships. Maintaining harmony and stability can also be really important, not having constant change or new faces or an evolving care environment. Aligning care with our person with dementia's wishes or values, right? So that again is reminding ourselves back to that the formula that there's the dementia is one piece of it, but there's a person there who has a history and has opinions and who's still experiencing their lives, and making sure we're continuing to pay attention to that as much as we can. It also is usually really important that we maximize quality of life and pay close attention to what a good day can look like for somebody. And so often, unfortunately, we need to be trading off on quality of life versus quantity of life. And that can be a very, very difficult trade-off to make. And there are some times, especially when we get to that end of life period, where the quality of life for most people becomes one of the more important things rather than quantity. And finally, it's important that we always respect the inherent personhood and dignity of our loved ones, with dementia, you know, with all of us really. But it can be easy for people to forget that when we see some of the things that have animated our loved ones fade a little bit. And so especially the very, very end stages where people aren't able to be their full selves anymore, that we continue to respect that personhood and dignity all the way until that passing away. So I think that's a lot of ethics to kind of throw at you all at once. Kind of this is very kind of heavy and deep stuff. So I don't expect you necessarily to take that all in and make sense of each of those all together. I kind of wanted to give you what I see as the stuff that's at stake when it comes to being a care partner, and the sorts of things that'll probably already are mattering to you and are coming up as you're thinking through and making decisions and caring for your loved one. I think I mentioned earlier that what's important to us is likely to change or shift over time along with the progression of the disease. So it could be that in earlier phases, and maybe this has already been passed for you, it was probably important to preserve that independence, to slow any kinds of progressions, and to try and maintain that level of function as much as possible. And towards the end, I think, as I already mentioned, the values of maximizing quality of life and that dignity piece become even more important. And so I think it's okay to notice that we have these basket of things that are really crucial in our lives, but they're not always going to be equally crucial as their circumstances change. The other thing to recognize, I think, is that we appropriately want to give very careful focus to the person who has dementia, but also multiple others can be affected by decisions relating to care. And so it's okay to keep that in mind. These include yourselves, care partners. I think we often recognize that the well-being of our care partners is crucially important, not only because those, you are humans who we care about, but also because your ability to be as well as possible will enable the person you're caring for to be as well as possible too. There's all other family members who may be involved who are affected, neighbors potentially, paid care providers, the public, co-residents perhaps if somebody's living in a congregate living setting. And so it doesn't mean that every time we sit down to make a decision, we have to give everybody equal voice, but I think it is appropriate to recognize that our decisions don't just affect ourselves or perhaps the person we're caring for, but it may affect our family and others too. And that's okay. That's fine to give some weight to considerations for those people as well. So it looks like we're going to get a question up. And is Arlene going to help me or do I do this part?
You can just read it out and they can respond.
Okay, so we have an interactive question. It's a very exciting technology. So as I think a person with dementia's capacity to make decisions change, we turn to A, advanced directives or other documentation of prior expressed wishes. These don't actually have letters, but the second one is opinions and views of the person with dementia expressed in conversations when he or she had decisional capacity. Third, how the person with dementia lived his or her life. The fourth one, what we think would be in that person's best interests. Or the last one, all of the above. So I'll give you a little bit of time to tell me what you think. So yes, all of the above, exactly right. I think that absolutely that's the right answer. And those are presented actually in a bit of a priority order. And the reason, I mean, we can go on and on about this, but not everybody has some of those advanced directives. Certainly, they're very, very important to have in place as early as possible. Let me see. Let me just pause there. So, but sometimes we don't have all that information, right? So it is okay to think about, who was this person? What kinds of decisions were they making earlier on before the progression of this illness? What kind of conversations did you have? Were you able to talk about, if this would happen, this is what I would want? These are all really important sources of information. On the last option, I used the term best interests, and you may have already encountered this phrase already. And that phrase tries to capture a sense of what kind of a typical person would choose in that particular situation. So if we can't know specific information about a patient or a person, a resident, whoever it is, then we can say, well, what would an average human want? And usually the sorts of things that we pay attention to are trying to minimize symptoms, maximize quality of life, if there's a potential to treat a condition and have it be cured. So those are the things we would think about when we don't have any other information to go on. But I would be happy to answer more questions about advanced care planning and what information we use at the end of the talk, I guess. So we touched a little bit on the goals of care, and a couple of other topics that we'll touch on are food and nutrition, medical treatment, and the notion of the good death. So as we all know all too well, there is a progression of dementia, and certainly things change over time. And the goals of treatment change. And I think initially there is a hope for cure or improvement or staving off any kind of a change. In the middle phases, eventually we're looking for comfort and for pain-free death. And this transition of goals is slow. It happens over time. And I think it's okay to be aware that goals are going to be changing, and that really getting back to that formula, which I'm just going to keep going back to because I love it so much, that we're trying to keep our patient as the focus of this consideration and involving them. I'm sorry to use the word patient. I realize I'm such a health person because it's so silly. Not, you're only a patient, unfortunately, in a hospital. So I'm going to keep saying person, but I hope you'll forgive me. But we keep our loved one, that person in the center as best as we can. So early, the goals tend to be trying to keep that health as well as possible, having a rich, fulfilling experience and a healthy life, maintaining optimism, hoping for a slow progression, and trying to just keep an eye on what's ahead and preparing for that. During that mid phase, there's that balance piece where things are changing a little bit. There's an interest in keeping our people safe and also enabling freedoms and liberties as much as is possible. And at that point, maybe there are some preliminary considerations about that quality versus quantity piece, and really asking what would enable a person to thrive. And I think that's almost always what we're trying to achieve. At that point, maximizing those loving interactions while people can still interact. One of the things that I'm sure you've heard, and I bet Arlene lives this every day, but I hear this and I think it's so powerful when I'm interacting with people who have some type of cognitive limitation or impairment. That someone reminded me once to say, you know what, she might not remember who you are, but she will remember how you made her feel. And I think that's such a reminder to focus on that interaction in terms of enabling a positive and warm connection, and worrying less about the accuracy of the facts and the details about who I am, which are at that point probably not very important. So as we're getting to that later stages, I think we may still be looking to maximize safety and liberty, again, as can be accorded. It's the ways in which people are able to make their own decisions are going to become smaller. How they're going to make choices in their own lives is going to change. As always, respecting the dignity of our loved ones and maintaining communications. And also that quality of life piece, recognizing that quality of life can take many forms. And one of the things that in healthcare, as healthcare providers, we're really good at doing, and it's not a good thing, is telling you what we think your quality of life it means to you. And that's not appropriate. And I mean, we do it because we're human. But I think remembering that what we're trying to keep on the top of our minds is what does our loved ones, what does quality of life mean for that person, and how do we know that, and what are we looking for to know that they're still enjoying things and smiling and so forth. Other things that may be goals in that later stages are, again, hope for reassurance, dignity, and love. We're also going to be paying attention to grief issues, and it's certainly a trajectory of multiple losses over time. Preparing for the end stages of this disease. And that piece of compassionate feeding and caring, I'll get into that a little bit more. But again, thinking about how to maintain those interactions that bring that quality of life in ways that are also reflective of people's physiological changes. When we come to the very end stages, maybe safety is not usually an issue anymore if there are folks who are perhaps mostly in bed. And at that point, the focus tends to be very much on comfort and providing whatever can bring any kind of thriving or joy. Food and liquids often provided, or mouth care, moistening of the mouth, little sips, things like that, and really trying to ensure that there is pain is managed very, very well, and that anything else that may be causing discomfort is addressed. Also, that goals can tend to be continued communication, visits with family and friends, touch, massage, all of those sorts of things, which again are very likely to be, adding to that comfort and to maintain those contacts with people. I think to not allow that person to be engulfed entirely by that illness, but to continue to interact with them as that person you've always known and loved. And finally, when there is that inevitable end stage, that hope for a good and peaceful death. So I'll say a little bit more now about nutrition. And this is going to sound a little bit clinical. I'm going to talk about studies and research, but I think it's really important to have this information. And I expect that this is something that you'll have access to in pamphlets and things. So it won't be the first time, or probably not the last time you'll hear about it. So one of the things that we know about dementia is that the neurologic control over the swallowing and oral control changes over time and eventually is lost. And this is an expected phase of dementia, and certainly difficult. And there may eventually be a time when that person will completely stop opening his or her mouth, when a person with dementia will stop opening his or her mouth. And typically at this stage, it's an indication that continued nutrition is not likely to be of benefit, at least not that full, complete nutrition that we imagine that a healthier person would need. So, I feel like this is out of order. All right, we'll just keep going. So the other thing, though, that we need to recognize is that, we talk about food, and that has a really strong cultural significance for a lot of us. I say here that it often represents love and care. And it's not simply calories or minerals and vitamins. It's an interaction often. And it may be that for people who don't have the physiological capacity to feed themselves, there's that moment of feeding, that sitting closely together, maybe some chit chat, that it's more than simply the food on the spoon or whatever it might be. It's actually an experience that brings a lot of benefit, I think. When it first comes to pass that it seems that a person with dementia is not able to safely swallow and their food anymore, there is a question sometimes about artificial feeding. And that there's a number of ways that can be done. So there's the nasogastric tube, sometimes called a KO tube, and that's something that goes in through a person's nose and down into their stomach and provides liquid feeding that way. And there is it's called nobody calls it this, but it's a percutaneous endoscopic oh goodness gracious, gastrostomy tube, pardon me. Most people just call it a PEG. And that is a tube that goes through the abdominal wall into the abdomen and will provide nutrition that way. So I think one of the big worries that I hear often from family and loved ones when it looks as though the person with dementia is no longer able to safely take in food by mouth is that we automatically need to provide food through or I'll call it nutrition through artificial means. And the intuition is that nutrition will offer benefit to the patient or person at that phase. And what we've learned is that intuition doesn't universally bear out to be true over time. So it doesn't usually, in providing nutrition through an NG or a PEG, doesn't usually improve nutritional status. It doesn't usually prevent aspiration pneumonia. So one of the challenges with eating at risk or consuming food by mouth when the swallowing reflex doesn't work very well is that liquids will go into sorry, someone asked a question, is that liquids will go into the lungs and that will cause a pneumonia, right? It'll cause an infection. And so you might think, well, if we put it directly into the stomach, that won't happen. But what we know is that the liquids that are put into the stomach sometimes go back up and actually go back into the pneumonia. So we're not actually preventing those through a PEG or an NG tube. It doesn't reduce the likelihood of pressure sores. So a dietitian will tell us that nutrition is usually really important for people who have a pressure sore in the healing of that. But they're finding that this mode of nutrition, providing nutrition for persons with dementia, doesn't really reduce that likelihood and overall doesn't increase longevity. We also find that sometimes people who have dementia, when you do put things up their nose or have a PEG, that this is something that can be very foreign. I mean, it's foreign to anybody who has it. It can be quite uncomfortable. And sometimes that can lead to people pulling at tubes, pulling out their NGs and things, and that can the pulling of that can be actually quite harmful, and so can lead to people being restrained so that they're not able to pull at those modes of feeding. And the other thing that sometimes can happen is it replaces that experience of sharing food. And then that completely goes away. We stop paying attention to that. And that's a loss, right? And so it's not to say that we would necessarily feed someone unsafely, but we need to keep in mind that exchange with a person, even if they're not able to take in any food at all, still having that interaction, that sitting closely, maybe some moisture in the mouth can still be a very beneficial thing. And one of the questions was, is this the same as intravenous liquids? And I know the answer is that those would be separate. I'm not a clinical person, but my sense is that it would be unlikely that they would use intravenous liquids for nutrition with persons with dementia. Another question was, is it unsafe to have someone eat food if they have to be told to swallow and seem to struggle to do it? So the question of safety really comes down to the speech language pathologist doing a swallowing assessment, or sometimes an occupational therapist, depending who's there. And so that person will be able to pay attention to the swallow and can give that assessment about the safety. I don't think it's necessarily unsafe if someone needs to be reminded to swallow, but it's quite a complex thing. So I think if you have some questions about that you would get in touch with the expert rather than me.
Yes, and I think the other thing is often families will be told that the type of food will be changed. So they will go from regular, what we would call solid foods, till then they will go to thickened, and then kind of those level, Catherine. So that's right. I think that's usually what happens. And I just want to check to make sure with the first question about it being intravenous liquids. Are you going to talk about the crisis or?
I don't think I have. Okay. But so that would be for hydration primarily.
Right. Yeah. And I'm wondering if that's where the liquid was.
For the intravenous liquids.
Is that the hydration question?
Yeah. I mean, I think at that point, hydration would be more about for comfort. But yes, so my experience in these decisions about nutrition and hydration at the end stages of dementia is that primarily people are talking about PEGs and NGs. And I think the way that you would think through whether or not to go this way would be similar to, like you sort of think about crisis along the same lines as you think about a PEG or an NG. And really whether or not it would meaningfully add to some kind of comfort or quality of life is usually the question at that point. I'm not sure about the potential harms of crisis, so that you'd have to ask, again, your most closest healthcare provider for that information. So when we look at some alternatives for nutrition and hydration, some of these more artificial means, there are alternatives. So it's still possible some for careful hand feeding to the extent that a person with dementia is willing and able to accept. So when that question about having to remind someone to swallow, so you may be in a circumstance where a person can safely swallow foods of a certain texture, so it could be like a minced diet or something, but may need some time for that to happen, right? So could get through a meal or whatever it might be, a serving, but it could take several, maybe over an hour, right? And with that coaching and reminding to swallow, and I think that is definitely something that we can strive to support people to do as much as possible. It's also sometimes something that people do think about, and I hope I don't bug Arlene by mentioning it, is whether or not there may be a little bit of risk that you think your person with dementia would want to take on. So that doesn't necessarily mean that people would be able to support a choice that would be a lot of risk. So, bringing in a steak for someone who has an unsafe swallow, well, that's not going to happen. But asking about, could I bring in a little bit of pudding or something that, some flavors that I know, mom or dad or so-and-so would especially like, or a little bit of brandy on the lips, So I think keeping in mind that certainly safety at this stage is important, but there still is room to bring in some of that quality and some of that pleasant experience of food and liquids. So to keep that in mind. I should also say, as I have here, that the PEG or the NG or the KO, whatever people are calling it, may be appropriate for a bridge period, for it to extend some kind of life, but it's not usually recommended for longer term, especially the KO or the NG, the nose tube. That's intended to be a short term intervention for anybody, not just people with dementia. So when we think back to our values, I think the ones that tend to be really important when we're considering issues of food and nutrition are, are we really creating benefit and promoting well-being by the decision that or by the plan that we have for food and nutrition? Are we minimizing those harms? Are we able to maximize freedom and independence? So are there certain foods that we know a person with dementia could eat themselves and other foods they wouldn't be able to, and how can we enable them that their own freedom to do that work, considering again quality of life and that personhood and dignity. And that this is my guess, and so you might be looking at these other ones that I have here and kind of imagining how that would be important to you in this decision as well. So I don't want to suggest that those ones that aren't checked aren't important. These decisions are very difficult. I'm not sure how many of those on the line have already been faced with some of these. I think that I just want to recognize that even though, we might be able to talk about the science behind it and the medicine and what we know about the effectiveness of this, it's not going to be an easy decision to decide to do only, so for example, only compassionate hand feeding. So I'm hopeful that you're able to have these conversations with each other, within your families and among other care partners, and certainly with your healthcare teams as well. So that was that. Are we happy to move on? I'm just wondering if there's any other questions on nutrition and food while we're on the topic.
So if anybody does have any questions on kind of that food nutrition, you can go ahead and type them in. We'll give you a few seconds. If not, then we'll just continue moving along.
Perfect. It was just an excuse for me to get some water. Although I do sincerely want to answer your questions. So I'll move us along then, and do feel free to type as we go, about some decisions for active medical treatment. So here there's two types of things I'm thinking of. One is treatment of other illnesses or conditions that may be present with a person with dementia. So I just have some examples here, cancers or kidney disease, joint deterioration. And then, of course, there's the treatment of the expected consequences or complications relating to dementia. And the primary one is pneumonia in this case. So again, I'm getting us back to this question of goals, right? What would our goals be? And those should, I think, a good decision is when our goals are clear and it reflects a hope that we can drive towards those goals. So the sorts of things that may be a goal when faced with a decision about active medical treatment could be, curing of a disease, prolonging life if there's a sense that if we're thinking about another illness is likely to truncate life, avoiding a premature death, so that's quite similar, maintenance and improvement of function, relieving suffering, improving quality of life, the preservation of control. And then the last one I have here might strike you as somewhat unusual, and it's in the achievement of a good death. And I think one of the things that comes up for me daily is the question, the observation that we can do this treatment, but should we do this treatment? And what do we think it would actually create for this person who would be having the treatment, and for the people around them? And sometimes what happens is that when we continue to pursue active medical treatments for whatever ailment, that we turn our attention away from the potential for a good death, and we actually set up the conditions to have a death that people would describe as not as good. And I recognize when I speak with people outside of healthcare that sometimes this idea of a good death sounds quite foreign, and some people will say, a death is never good. It's sad. It's not a good thing. And I agree that it is very sad, and we want to make sure that we can have the people we love around us as long as possible. But we all will die, and there are certainly qualitatively different types of deaths, whether it's a death with pain, death alone, death hooked up to machines and ventilators, death with lots and lots of drug, so there's all sorts of things where it's possible when we're really seeking to actively treat and actively treat, right up until that person may pass away anyway, that we inadvertently create a death that's not as good as it could be. So I encourage all of us, and this is not only for folks here, for all of us to think for the future, for our loved ones, for ourselves, what does it mean to have a good death, and what may actually be an impediment to that? So when you're making those decisions about medical treatment, I think we need to be considering the change that any treatment may be able to create. So maybe we're going to be achieving some of that comfort or function without too much intervention, but also paying attention to some of the harms. The other thing to keep in mind is that, as we all know all too well, dementia is incurable. And so while we might be able to treat other health things that are happening, we're not going to be in a position to cure the underlying condition. And so it can be tempting to try and to address all these other things that are maybe addressable in a sense, but ultimately won't change the fact of the dementia, unfortunately. The patient's goals of care can and change over time, which I've said a few times. And having clarity about these goals enables us to have that, maintain our hope, and to adjust our goals and expectations appropriately over time. So I've already touched a little bit about this, and I think that there's a multiple dimensions of a good death. One of them is preparedness. And connected to that, I think, is how we choose to spend time when we believe that perhaps we're in the last weeks to months of life with our loved one, and how we want to spend that time together. There's also the consideration of pain and comfort. Sometimes when there's an active treatment going on, there's less focus on managing pain, for example, or those treatments themselves can be quite uncomfortable, requiring blood work every day and things like that. There's also the level of medical intervention, which I touched on, right? We have all sorts of gadgetry that we can use, but it's not always ultimately the best choice to use it. So, and generally when you ask people, what does a good death look like for you, we're not imagining that there's going to be a lot of gadgetry involved. So when I say that, I'm talking about, ventilators, dialysis machines, or, some tubes and so forth. And then of course the presence of family and loved ones. And again, when we're in that active intervention mode, it can be more difficult to ensure that we surround a person who's in their final stages of life with friends and family. Right. And the last piece, I won't go through this, is this having affairs in order. And I think it's a source of great peace for people, either for an individual themselves or for the person caring for them, to know that the affairs have been dealt with appropriately ahead of time. I think there's a readiness that brings. So just a few questions for you on the slide there, about to think about this a little bit more, and what it would require to work towards the conditions where this can take place. So there's a lot of decisions, I think, that, and I'm making up a story that you've already been through making. You've been making these decisions all along, given that you're at this phase in this set of this part of the courses that the Alzheimer's Society offers. So I kind of feel like you're the expert on this stuff. But these are the sorts of things that I think help us make good decisions. And these are the things that I think about when I'm asked to support healthcare teams and patients as well. So some of the questions that come up are, what do I know for sure about this situation? And as a part of that, is there any information that I'm missing? And can I find this out? And I can't think of how many times I've been invited into a situation to do some kind of consultation where simply getting the good information on the table for everyone to see actually resolves the issue. What's important to the person with dementia that I'm looking after? And who else might be affected by the decision, and what's important to them? And that would include you as well. I think we can become very focused on the person with dementia. We need to also recognize that you as a care partner have a stake and are affected by all of these decisions quite significantly. What are the options that are in front of me? And that's a good question, I think, to ask at any kind of appointment. Sometimes we find ourselves with healthcare professionals who don't so much offer options as they just kind of tell us what's going to happen. And I think it's always good to kind of hold their feet to the fire a little bit and say, okay, I hear you that you're making this recommendation, but what are the options here? And which option best gives us what matters to us, right? So which is the one that's really going to make sense given who that person with dementia is, their context, you as a care partner, the other people who are involved. I'm not going to go through this because I feel like I've covered these points already, but if this is something you might want to look at if you happen to download the slides later. But it does, again, it's sort of taking us back to these things that after, quite a few years, and from my end of things, working with patients and families and residents and just plain old people, this is the stuff that comes up again and again and again. And really, the challenge is to try and make decisions in our lives that enable us to live this, to live these things that matter, and to decide, here I am today, what will be the thing that matters to me most, or to the person I'm caring for, to my family, and so forth. So that was a lot of dense, heavy stuff all at once. And I'm hopeful that you'll have some questions, or if there's anything else that you think I might be able to answer, I would also welcome that too.
Sure. So while everybody else is having a chance to type your questions or think about a question you might want to ask Catherine, I guess, Catherine, my question, I know we usually talk about this when we do our live sessions, is so a clinical ethicist. I know I had never heard of such a person before until I met you guys. So for everybody who's, whether it's they're on tonight or they come back and they're listening to this at a different date, what is your role and how would your role compare to like our family members that the Alzheimer's Society serves? Can they call you? You do have your phone number sitting there and your email. So I just want to clarify for families out there, is this an open invitation if they're struggling when they're at this end of life? And if they're not in the city of Edmonton and they're in outlying areas, would other towns, like where are clinical ethicists, how do we find them? If you could kind of just address that.
Absolutely, and thanks for the question. So this, there are 10 clinical ethicists, and I work in Alberta Health Services. So we know that that not everybody is directly connected to Alberta Health Services at all times, but certainly that is something. So the Clinical Ethics Service in Alberta Health Services is mandated to serve people who are under the care of Alberta Health Services across the continuum of care. So that includes home care, any kind of residential care, usually if it's an AHS connected facility, and even if it's private, there's still some leeway there, and certainly any kind of healthcare center or hospital. There also is a clinical ethics services in Covenant Health if you happen to be connected to the Misericordia, the Grey Nuns, or any of their long-term care facilities. And so if you are clearly in an AHS facility or getting home care or anything like that, you can certainly go onto the website if you feel you can do that, and just type in clinical ethics, and that will give you some of the information about our service. I have put my name and number here, and I would absolutely welcome an email or a phone call from anybody just looking for some navigation help, because goodness knows that it can be really a brutal challenge to navigate our health system. So it is also, there's coverage across the province. So my mandate is to help at the Royal Alexandra Hospital in Edmonton and also the entire North Zone. And I frequently get calls from healthcare providers and patients from all over the North. And there are ethicists assigned to every zone. So there is no part of Alberta geographically where you wouldn't, in principle, have access to someone. Although the way that that person could help may vary a little bit, as is true with most healthcare, unfortunately. So that's that. And if you're not sure, I can, do send me an email, or just you can give me a quick phone call. And again, if you search on the internet, we have a site on the Alberta Health Services webpage that describes a little bit more. So should we read the comment, or?
Yeah, I think everyone can see it.
Okay. So. Yeah, I think, and the point I hear you making, leap year, is that this is emotional, right? And I'm presenting this in a fairly kind of rational way, in a way that maybe doesn't acknowledge some of the emotion that's involved. And I think that absolutely that's there, and we need to honor that. And it's gonna sometimes make it more difficult. Yeah.
And I think that's the other thing too, is that a topic like this, it's really good to sit back a bit and do some reflection. And if you go to download our information in the next couple of days, you will see a page of questions for reflection, and they're really to make you think about the talk. And as Catherine said, it can come across very kind of, this is how it is. And as part of the Alzheimer's Society, we are here to help you go through that journey. We have our partners like Catherine who we can reach out to, and we're really here to help families go through this. And we know it can be a difficult and trying time. And so if there's anything we can do to help you through that, don't hesitate to call, whether it's the Edmonton office or any of the other offices, our offices throughout the province and the Northwest Territories. We are here to help you through that. So don't hesitate to ever reach out to the Alzheimer's Society or any of our professional speakers who come in. We'll just give a few more seconds if anybody else has any questions for Catherine. Other than that, we would thank you for joining us, and thank you to everybody who's participated. And Catherine, thank you for giving up your time this evening. Our CEO, I see, sends you thanks as well. And if there's no further questions, we'll sign off, and you will have the chance to download those documents by coming back in a couple days and looking for them on this site. If you cannot find them, again, please don't hesitate to get in touch with your local office, and we'll make sure we can get them into your hands. So it looks like there's no other questions, so we will sign off from our end. Thanks everyone, and have a good evening, and I hope to see you next week.